My disclosures and the topic of my talk. So who are we? CML Advocate Network is a global network of leukemia patient groups connecting 77 organizations from 61 countries. We have a website with two parts. The open public part has, among other things, the directory of all CML patient groups around the world, and the closed members-only part has a social media platform which allows our CML patient advocate members to collaborate, build skills, coordinate campaigns, build partnership, and share knowledge. It was founded in 2007 by 4 CML patient advocates. So what did we want to do and achieve in our study? We are very aware that prior studies demonstrated that non-adherence is a key issue in CML. It started with the Adherence study, followed by the Hammersmith, and then the Bazeos in 2009 had a clear clinical impact between non-adherence and the chances of reaching an MMR. So the objective of our patient-driven study were to understand why patient behavior associated with adherence, they help identify the true issues behind non-adherence. We wanted to explore if there are any cultural influences of adherence on regional and country. And we wanted to support, eventually, the development of physician and patient tools to improve adherence and patient outcome. The study was truly global, and we received 2,546 responses from CML patients from 79 countries. We had 2 arms. One arm was the online, with 2,151 responses, and the patients were recruited by the members of our association. And then we are concerned that the patients who are recruited online may not represent the real CML community, and because they are members of CML associations and they're internet users. So with the support of the Giora group in Italy, with the FLMC group in France, and the German CML group, we ran a parallel paper survey, and we recruited 395 patients through this arm of the study. So we also incorporated into our study the Muisky Adherence Scale, which is internationally known adherence scale used in many other diseases, not only CML. It uses a series of 8 questions, and then patients are classified by algorithm into 3 groups of adherence. You can see that in our study, 21% were classified as low adherent, 47% as medium, and 33% were classified as high adherent. I must stress that the results presented here are initial, descriptive findings only. We will follow up in-depth analysis, including multivariate analysis, and we'll also do specific countries. So what about non-adherence? You can see here the results for the patients reported non-adherence in the last months before they answered the survey. You can see 29% of the patients reported they have missed doses accidentally in the last month, and you can see that 11% of the patients reported that missed dose intentionally in the last month. And what's more important, we asked what was the average dosage they have missed accidentally, and you see that the number was 3. If you remember the Bazeos study that I mentioned at the beginning, there was a line of 90% dosage, and patients who were taking less than 90% had only 20% chance of reaching an MMR, as patients who were taking more than 90% had 80% of reaching an MMR. So 3 average doses a month represents this dangerous line. We asked the patients to self-rate themselves on a scale of 1 to 5, how is their adherence. You can see in the yellow that 74% of them said they always stick to the therapy as prescribed. But we went further and analyzed what is the adherence of this 74%, and we found out that 90% of those patients who said they always take the medication as prescribed actually has missed dosages accidentally in the last months. So we think this is a clear indication there is a gap between perception and reality of the patients. You can see here in this slide, which is a little bit busy, the non-adherence, both accidental and intentional, for the last year. The 2 lines in the middle represent the global average. And you can see on the top right side of the bar, countries which are above global average average for missed doses. And you can see that the USA and Serbia, and also Russia, stand out through the proportion of missing doses, both accidental and intentional. And you can see on the left down part of this chart, the countries which are below global average. And you can see the Netherlands, Germany, and Slovenia among those countries. And you can see the rest of the countries are in this chart. So what are the reasons for being non-adherent for patients? So, as we said, there are two types of non-adherence, and if you look through the reasons of accidental non-adherence, so forgetting and interrupting routine are the main two reasons. But if you go to the reasons for deciding to miss intentionally, you see that not feeling well and the intention to reduce side effect are the main two reasons. We also ask what type of side effects the patients were trying to minimize. And interestingly, we found that 79% of the patients said they were trying to minimize gastro side effect, but also 21% that they were trying to minimize mental side effect. I don't think that mental side effect is one of the side effects mentioned or associated with using TKIs, so this is something that we think we should explore further. We wanted to see how important is routine for patients who want to become adherent. So you can see in the yellow part of the bars, these patients who feel that routine helps greatly. And you can see that there's a big difference between the high and the low adherent. As 76% of the patients who belong to the high adherent group said that routine helps greatly, but only 56% of the patients in the low adherent group said the same answer. We found that patients in the low adherent group are usually younger, and you can see this from the black part which represent the low adherent, and this is the age, and you can see the green part of the box, those are the high adherent patients, and you can see them in the older age, the higher percentage. One of the advantages of such a research being done by patient organization is that we can ask questions which are related specifically to specific treatment. And you can see here the division of the three main used common TKIs and the division to the type of the adherent groups. So we found that imatinib seems to be linked with higher adherence, and nilotinib is more prevalent in the low adherence group. You can look at the numbers, and you can see that only 19% of the patients who are on imatinib belong to the low adherent, and 27% to the nilotinib, and the opposite is for the high adherent group. 25% from the nilotinib users belong to the high adherent, and 36% of the imatinib users. Another point we wanted to check if there is any difference on adherence according to the time of the day the patients are taking the medication. So we found out that the dosage which the patients are taking in the evening is the one that they are more in danger of missing. And another thing we checked is how many times a day a patient is taking the medication. The blue, dark blue represent the patients who are once on the daily medication, and the lighter blue are the patients who are twice a day daily medication. And you can see the difference between the high and the low groups. The high adherent patients, only 21% of them belong to the higher, 21% of the high adherent are on twice a day medication, but patients who are in the low adherent group, 35% of them are taking the medication twice a day. We found also that there is direct link and correlation between the perception of the patients, how the drugs they are taking are influencing the quality of life. So if you take, for example, you see the lines, the dark one represent the low adherent and the green one represent the high adherent group. If you take a question, for example, I worry about the long-term effect of my CML medication, you see that almost 70% of the patients in the low group are worried, but from the high adherent group, it's less, half of them are 35% are only worried. And if you take another question, like it's okay to miss few doses of my CML medication now and then, you see that less than 10% from the high adherent patients feel that way, but almost 30% from the low adherent patients feel that it's okay to miss. What about the relationship between you, the doctors, and the patients? We found out that adherence is strongly influenced by the relationship of the CML patient and the doctors. We ask a series of questions, and I'm just going to show two of them. And you see that we ask how often or how likely are you to discuss missing dosage with your physician? And you see that the patient who said, yes, I will always discuss this with my doctor, both accidentally and intentionally if they miss, 83% of the high adherent patients said that they will discuss it, but only 47%, which represents less than half of the low adherent patients, will discuss this with the doctor. And it's very similar between the two types of non-adherent patients. Another question we ask, how satisfied are you for the information you are receiving from your healthcare provider and how you perceive them to be approachable? So you can see on the left side downstairs, the patients who are very satisfied, 69% of them belong to the high adherent, but only 45% of the low adherent patients are satisfied. Maybe more importantly, only 4% of the high adherent patients say that they are not satisfied at all, but among the low adherents, 4 times more, 16% of the patients feel that way. And it's very similar about the perception of how approachable the physicians are. 73% of the patients feel that in the high adherent patient group feel that the doctors are very approachable, and only 53, lower percentage in the low adherent. So we see direct influence of these questions of the relation between the patient and the doctor's own adherence. Or how about tools that drive and improve adherence? You see in the blue part of the bar, those are tools the patients are already using. And you can see the reminders from family members and also the pillbox dispenser are the two tools which are being used mostly now by the patients. And the yellow part of the bar represent tools that patients said they will not use. And you can see that most of the tools, including refrigerator magnets, SMS reminders from doctors and nurses, patients do not want to use it. We asked the psychologist who was consulting us, why is that? And she said that patients don't want to be reminded on a daily basis that they are sick people. And that's one of the reasons. There was one exception, and we found out that 26% of the patients will be willing to use a mobile app if it was available to them. So this might represent something we'd like to develop in the future. So in conclusion and recommendation, we think that you, the hematologist, you should not take the patient's adherence assessment for granted. You have a central role in driving adherence, and you should discuss the impact of the medication of patients are taking on their life, especially related to side effects and quality of life, which are two main drivers for adherence. You should highlight the impact of routine when you discuss it with your patients. You should pay particular attention to more at adherence risk groups, like the younger patients, the patients who are longer time on treatment, the patients who are on twice daily regimen and suffer from strong side effects. From the patient perspective, we think that there is a future potential for tools to develop, but we think that priorities should be put on changing the mindset of the patients who belong to the low adherent. And finally, you, the hematologists, and we, the patient advocates, we have one combined mission, and that's to improve adherence and the outcome of the patients. I would like to thank all the thousands of CML patients who participated in this study, to all the CML patient groups who did an outstanding job to recruit the patient in such a short time, to the member of the raw group, who you can see the picture on the right and the names on the left, and that's including the advisors that are following us and supporting us. And last but not least, the German CML group, study group, the GMEMA group in Italy, and the French Free LMC group. Thank you very much.